this. But yes, so if you need to, I guess, yeah, you can email it to me, or you can even print it here in the LRC if you need to. But you can email it to me, and I can print it out, and that way we have it in your file to show that you've received that training, and you can do. That way, if the clinical site or something's like, did you do the Da Vinci training? You're like, yes, I did, and the certificate of it is in my. Um, check. Hello, hello. Somebody said that they couldn't hear, so I was trying to test it. Can you hear me now? Can you hear me now? Can anyone hear me? Yes. Okay, good. Okay. Make sure I got everybody down here for attendance. Yes, 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 yes. My man Marcellus. Mr. Philippe. I know where AA run is. Let's go on through his phone or something. Okay. Later. So today we're going to be talking about laparoscopy, minimally invasive type stuff. We've already gone over this once before last term. So this should be relatively quick. So what we're talking about here is like this minimally invasive, right? This is where we make these, small incisions, try to do most of our work from within the body without having to make these huge incisions and stuff like that. Partially, for patient recovery, right? They're better recovery times. Then they don't have to stay in the hospital overnight, stuff like that. The big, less of a draw on like insurance companies and things like that. But then the the opposite kind of comes into play too, because these equipment and supplies and things that we need in order to do this are a little more expensive than the traditional way. So it doesn't really save a whole lot of money in terms of like the insurance and stuff like that. But what it does is it helps those patients get better faster. It helps them recover faster. They can get back to work. They don't have to spend the night in the hospital, stuff like that. So some types of like, minimally invasive type stuff can be endoscopy. Typically with minimally invasive, we're using, like a camera and light cord and scope, or we're using like maybe even a microscope. If we're doing minimally invasive like spine surgeries and things like that, then we'll be using like the microscope. We'll still be working through, small incisions and using different retractors and things like that to kind of make those small incisions as big as possible. But we'll probably be bringing in a microscope so that we can actually see, down into that hole and see what's going on, get some light down in there. But endoscopy itself, like the endoscopy department, we're talking, colonoscopies, EGDs, or esophageal gastric dilation, and those kind of endoscopies where we're going to be going down the esophagus and looking in the stomach, and even looking into the duodenum, looking into the biliary tract, things like that. Trying to free up blockages. A lot of endoscopy is diagnostic, but can also be operative in terms of taking little tissue samples, or actually even clearing out a blockage in the common bile duct of a stone, things like that. So with endoscopy, remember that all of that stuff is like those cameras and scopes and things like that are not sterile, right? They've gone through like a high level disinfection and things like that, but they are not considered to be sterile items. So they're not critical items. They're semi-critical because they're going to be in contact with mucosal membranes. Pardon me, I'm sorry. I've been just talking all morning, so I'm trying to get some oxygen. But we're going to be in contact with these mucosal membranes and things, so they're semi-critical items. Those items that we'll use, like the camera, the light cord, the scope, and stuff for laparoscopy, all of those are critical items because now we're actually entering into a sterile cavity within the body. Some of the principles or the things to take away from minimally invasive surgery. No matter what kind of minimally invasive surgery you're doing, there's always some kind of telescope involved, right? That's the scope that'll connect to the camera, and then the light cord will connect to the scope itself. There has to be some kind of cannula inserted, whether that be into a joint or into the abdomen or into the pleural cavity. Wherever it is, we got to put a cannula so that now we have kind of a portal between the outside and inside where we can, insert and remove instruments and things. But that cannula helps protect the body wall, right? We don't just make like an incision and then go in and out of that same hole, because then we're constantly going back and forth through that tissue and kind of tearing it up a little bit. So we always have to have a cannula in to help protect that. And then it also gives us kind of a seal, right? So that we can insufflate, or we can, distend a joint or an abdominal cavity or something like that, so that we have room to work. And we need that to be sealed so that we don't lose either the fluid we're putting in or the air, and then that diminishes the amount of area that we can work with our instruments and things like that. And then there's that manipulation of those telescopic instruments where we have to understand that by looking while we're watching it on the screen, that our movements are opposite of where we move our hand. So if, say, we want the tip to go towards the right on the screen, we have to actually move our hand to the left because that'll get that tip to move. The reason all that happens is because with the instrument in the cannula acts as kind of your fulcrum. Fulcrum is, if you think about like a seesaw, that part in the middle where it moves along is your fulcrum. So the cannula is acting as that fulcrum when you're moving the instrument around back and forth. You want the tip to go to the right, you move your hand to the left. You want to go to the left, now you move your hand back to the right. Same thing up and down, right? If you want the tip to go up, you drop your hand. If you want the tip to go down, you pick your hand, you bring your hand up. A lot of different specialties use these minimally invasive techniques. You've got general, GYN, urology, orthopedics, neuro, who else? Yeah, ENT. ENT does it into the nasal cavities. And then also doing like esophagoscopy, rigid esophagoscopies, rigid bronchoscopies, things like that. All different kinds of surgical specialties use it. But they all have kind of those same principles that we talked about back here. Right? You got to have some kind of cannula. You're using a scope. You're protecting the tissue that you're actually going into and past. Things like that. You need that protective seal. You're going to have an imaging system, right? You're going to have a box that the light cord plugs into, a box that the camera plugs into, a monitor so you can actually see, what the camera's picking up. You're going to have insufflation or irrigation, depending on, where we're working. Are we working in the abdomen? Then we do our insufflation using air. Right? If we're working in like one of the joints, elbow, wrist, shoulder, knee, ankle, we're using irrigation, typically saline. And then the balloon expansion is for if you're doing a laparoscopic repair of inguinal hernias. Right? And that balloon expansion helps kind of like break and separate those tissue planes so that you can see Hasselbeck's triangle easier. And that way you can determine whether or not you have a direct or indirect hernia, right? A lot of advantages, to minimally invasive, right? You can use it for a variety of different surgical procedures, especially in the abdomen, right? We can do a splenectomy, a cholecystectomy, a liver resection, colon resection, Roux-en-Y gastric bypasses and Lapp-Nissen fundoplications and all kinds of different, we can work on all kinds of different organs. We can repair hernias and things like that, all through this minimally invasive, giving those patients that decreased tissue trauma, right? Reducing the amount of blood they're going to lose. Because we have a lot of different types of instruments and things for coagulation now, right? The harmonic scalpels and the ligature devices, things that don't require us to have to like clamp and tie off anymore, which was one of those main reasons why we had to open. Because we have these big instruments and things like that can't fit into these little tiny incisions. So we need to be able to actually have our hands on those things. That's why we needed open procedures. But now we've developed instrumentation that can do all those things laparoscopically or minimally invasive. So we don't need to open anymore, to tie off those vessels and stuff like that. We can just kind of burn through them and move a little quicker. Faster recovery for these patients, right? Now, things that used to be inpatient procedures, like hysterectomies and things like that, are now outpatient procedures. Patients going home within a few hours of having their surgery done. Decreased pain, because we didn't make like this big giant incision in you, right? We didn't have to like really tug on structures and things like that and put in these big heavy retractors, right? Which has then led to an increase in patient satisfaction. Like, oh, I didn't have to, patients going in having hysterectomies now are remembering when their mom or their grandmother had to have a hysterectomy and how long they were in the hospital for and how long it took them to recover and things like that. And now they didn't have to go through all that. So they're, happy, pleased that, that was actually a lot worse than I thought it was going to be. Less costly is debatable. Yeah, you're not, uh, the patient's not staying overnight and billing insurance and stuff like that, but we are having to open more, supplies and more instrument trays, right? You got to have one that's got your light and your camera and your light cord in it. You have another one that's got, your scopes in it. Then you have your lap chole tray or your laparoscopy tray, and then just in case you have the major tray that you opened and counted, in case you had to convert to open, right? So little more to it. So some of those things can kind of pile up and take the place of something that was, like the patient not having to stay overnight. Okay, the insurance company's not having to pay for that, but then there's the cost of like the 4 trocars we had to open and the stapler and the ligature and stuff like that. So that may offset some of that cost. Some of the limitations, right? You have the advantages. These are some of kind of the disadvantages of minimally invasive. Uh, there's a big learning curve to it, for doctors, even techs, because there's times that, we're going to be the ones controlling the camera. And, it takes a little bit of getting used to, watching it up on the screen and moving the camera around and getting yourself kind of orientated to what's what, right? To get that kind of, geez, um, kind of be second nature for you. Right? What happens if you lose power? Right? The hospitals are supposed to have like, battery backup and generator and things like that, but you could be in the middle of using, some kind of cautery device, and then the power goes out, and now you've lost your image, and now the whole system's got to kind of reboot. There is a computer on board, so it has to go through like a reboot before you get your image back. So basically, surgery has to stop. Um, some of the equipment and instrumentation that you need is expensive. Uh, especially like the Da Vinci robot. Just the robot itself, the 3 pieces, the surgeon console, the imaging tower, and the robot. Just those 3 things are a little over $1 million. Now, that does not include the camera and light cord, the scope itself, the special instruments that you have to have, all the draping for it. What else goes in there? Like the little seals and their own version of cautery stuff, and all of that then gets extremely pricey, especially to start off, a new robot system. But the operative site, when we're working laparoscopically and minimally invasive, is 2-dimensional because you're just looking at it on a screen. If we had the patient open, that would be 3-dimensional right in your face, right? You could touch it. With the robot, we see it, those of us who are up at the field, because we're still watching it just on the TV screen. We're getting a 2D image. They have made it to where you can make that a 3D image, but you have to wear the special 3D glasses to see it in 3-dimensional. For those of us who are up around the field, not as important to see that in 3 dimensions. But the surgeon in their surgeon's console, when they're looking in there, they see it in 3-dimensional, which has made the robot that much better than the laparoscopy type versions, because now you're taking away some of these limitations, some of these disadvantages. But not everybody's a candidate to have things done minimally invasive. Could be that there's too many other tissues or adhesions or something in the abdominal cavity that are going to get in the way that they have to work through. So it's going to cause more problems than good. I'm sorry, more problems than good. I swear to you, I did go to bed on time last night. It's not from lack of sleep. I think it's just from a lot of talking and blowing off a lot of air. I need to get more back in. Anyway, there could be other reasons, patients got, heart issues or things like that, that they can't have that insufflation put into them because it causes too much internal pressure that is going to put pressure on the heart. So some reasons why not everybody can undergo minimally invasive, which is why it's still a good idea for the doctors who are out there now and like residency and stuff like that to still stay sharp on how to do procedures open. It's what they're starting to find now is that the surgeons that have come out, of medical school over the last about 10 years or so, they're all taught, like the main way that they're taught is minimally invasive. And then every once in a while they get to see like an open case, which is opposite of the way it used to be. It used to be everything was open, and occasionally you would see something kind of minimally invasive. With it being the opposite, if they get into trouble, laparoscopy, through the scope, and then they need to convert to open, what we're seeing is a lot of them struggle when they have to switch to open. They're very good and proficient under scope because that's what they got a lot of practice on. And then you switch to open, and then things tend to slow down a lot. And then you become very meticulous because they haven't had as much practice doing it open that they have doing it through the scope. Some risks, right? Appropriate actions by us, as the staff, as far as knowing our equipment, making sure that it's clean and gets cleaned properly, things like that, right? That they function properly, that your light cord isn't like broken so that it's not going to pass any light down it at all, stuff like that. That you're, checking your instrumentation and making sure that things that are supposed to be insulated are still insulated. There's no cracks or holes in the insulation that could potentially leak out some of the electric artery and things like that. But the same risks as far as like risk to the patient, infection, hemorrhage, all that kind of stuff is still the same amount of risk because we're still dealing with the same structures. We're still ligating the same blood vessels. We're still, performing that. We're still accomplishing the same goal that we went in to do that surgery with. You understand what I mean by that? So, like if we were doing an open appendectomy versus a laparoscopic appendectomy, at the end of the day, we're still removing that appendix. So we still have to we still have to cut off its blood supply. We still have to ligate the appendiceal artery. But in laparoscopic, we can do that with a stapler. Open, we're probably clamping, cutting, and tying it off, right? Clamping and tying it off. In open, we got to put in that purse string. Laparoscopic, we don't because we're stapling that appendix off right at the cecum. So, just depending on what you're doing, we're still accomplishing the same goal. So your risk is still going to be the same as it was, whether it's laparoscopic or open. Some of it is based on the condition of the patient, right? What kind of other comorbidities What other kind of disease processes does that patient have going on? Right? Positioning, right? Are we putting pressure on an area that we shouldn't be? That kind of thing. Right? Are we using, the insufflation or the irrigation? Are we using the correct insufflation? Did somebody, when they replaced the tank, did they make sure that they grabbed the CO2 tank and not the nitrous oxide tank? It could be a very bad thing if you're using nitrous oxide to insufflate the abdomen. Is the abdomen still going to insufflate using nitrous oxide? Yeah, because you're still pumping a gas into a confined space. It's still going to cause it to go up. But the problem would be when you ignited the bovie or any kind of heat source inside, you could cause an explosion inside the abdomen, which would then blow out, right? Same like with the irrigation. If you're not using something that's isotonic to the body, then you can be causing damage to those tissues. And then we talked about equipment failures. So some of it's going to depend. So that, like, if you're doing a like a cholecystectomy, you're removing a I'm sorry. The question is asking if patients are going to be in the same position for open as they are for laparoscopic. No, because if we're doing a case open, we can get in retractors to hold things out of the way, like especially the bowel, and think that's what's trying to cover up what we're trying to go after. Laparoscopy, through scope or minimally invasive, the ports that you put in, like let's say we're taking out the gallbladder, right? We're going to put in 4 ports, 2 on the patient's right side, 1 at the umbilicus, and then 1 in like the left upper quadrant. The 2 on the right side are for your graspers to grab a hold of the gallbladder and liver. The 1 at the umbilicus is for your camera or your scope. And then the 4th one over in the left upper quadrant is for your okay. I'm being told by Mr. Ortiz to be aware. Let's see. So we have not been told that the COVID vaccination is required by the site, but it is an ongoing discussion. And that if and this is all still being discussed, but if you decline the vaccine, it may mean withdrawal from the program. Just letting you guys know. Ortiz says that he will talk with you guys as he finds out more and more information on that. What were we talking about before that? Minimally invasive. Distracted me. Oh, positioning. I was asking the question, right? Positioning. So, with an open procedure, say we were going open, doing an exploratory laparotomy, that patient's laying supine the whole time because we can put retractors in and hold stuff back. When we're in with the scope, we can't really put all those retractors in because we're putting in specific things into those ports. We need those ports for specific instruments. And we don't really have the room. We don't want to put an additional port just to put in a retractor because now it's an extra incision, that kind of thing. Maybe something they didn't talk to the patient about beforehand, told them, hey, you're going to have 4 small incisions. Now all of a sudden you have 5, that kind of thing. So that's where we're going to change and do the reverse Trendelenburg. We're trying to get those intestines to move and that way, therefore, be out of our way. So yes, the patient will still be in supine, but it'll be a modification of supine. Whereas the open procedure, the patient would just be in that straight supine the whole time because we would put in retractors or like lap sponges or something like that to hold the bowel and stuff out of our way. No, because typically, like if you're gonna do a bowel resection laparoscopically, most often it's going to be for those like low anterior type resections where you're going to be putting in the stapler in from below. So you'll have a second table that's kind of like your dirty table where you have all that stuff to go below with. And then if there does come one where you are actually going to do a resection up on the field and do a reanastomosis up there, like the way that we did it in the lab with the GIAs and stuff like that, then what they would do is make like a mini laparotomy incision and bring that section of the bowel out and do it kind of open that way. So then our bowel technique would still be the same. But for most of the time, all the stapling and everything happens inside, so you never actually open the lumen of the bowel to the abdominal cavity, to the sterile area of the abdominal cavity. It's always sealed off with the staple lines. Miss any? Yes, converting to an open case. So never a good time unless you already have pretty much all the stuff you need to go open with already up on your field and counted. Otherwise, you're doing a little bit of running for about 15 minutes because you got to clear the room because you have your laparoscopy tray sitting there, as your main tray. You have to take all the stuff that belonged to that and either put it back in it and pass the whole thing off the field, or just pass off those stringer of instruments, or you're going to have to add those stringer of instruments in to the whole count. So they get added, or what's called married, to the major tray. So what you would do is take your back houses, put them with the back houses off your major tray, put the mosquitoes with the mosquitoes, the cryos with the cryos, and then you would count them all together. But it's got to be done quickly because the surgeon is going to they'll be, looking through the scope, messing around with tissues and stuff like that. And then they'll be pulling the scope out as they say, oh, we need to go open, or we're going to convert to open. And they're going to take that scope and camera and everything and put it down on your Mayo stand and then ask you for a 10 blade and some laps. Well, typically for laparoscopy or laparoscopic, procedures, you don't have any laps on your field. All you have are Ratex. You don't have a 10 blade. You have an 11 blade to make stab incisions with. You don't have a major tray. So you have to get all these things. Typically, they're going to be, especially if it's suspected that you're going to be going open. If it's suspected that you're going to be going open, because I've been burned way too many times with not opening that major tray and counting it. and being ready. So anytime I do any kind of laparoscopy case other than a nappy or a gallbladder, because those are pretty standard and straightforward now, I'll have a major tray on my field open and counted. And I won't use the stringer of instruments that come in the laparoscopy tray. I'll pass those off before we count. And then I'll just use the instruments out of the major tray. That way I don't have to, hey, can you open that? And sometimes the surgeon will take that scope out and say, we need to go open, give me a 10 blade. And you're like, oh, can I get and your nurse isn't in the room. Now you have nobody to help you. And the surgeon's like, come on, let's go. I need that. What? And, and he may come across, like a bleeder or something, accidentally nick, an artery. And he needs that stuff now. So, but you got to, quickly move out those laparoscopy instruments, bring in your major tray, get the stringer out, get set up as fast as you can, get a count in. And then, if you added up laps, the 10 blade, all that stuff's part of the count. It all has to be done. So this is where your case planning comes in. And you being ready. Like you can, if you don't open the major tray, but you have the major tray over on a ring stand with all of the supplies on top that you would need in case you went open. That way the nurse can, pop all that stuff to you real quick, pop open that tray, and you're good to go. Get it counted and start going. This all can be done. What would you think the number one priority is when converting to an open case? What's the first thing you should ask that circulator for? What's the first thing we do in surgery? Not hemostats yet. Got to cut them, right? We need that 10 blade. That's the very first thing. We need that 10 blade. And you get that loaded up on the number 3 knife handle and hand it to them. They're going to make their cut. They already have a bovie. It's already up on the field. And they already have suction. What do you think's the next thing we need right after the 10 blade? They're going to need something to see where that blood is coming from. Lap sponges, at least 2 packs to start with. So you'll have 10. So the 10 blade and the sponges should be the very first 2 things that get open to you. And then your major tray. Because after he makes his incision, no local, no, you won't do any injections. If you're doing a big abdominal incision, you will not inject local anyway. Because there's the muscles and all that kind of stuff. There's too big of an area to get that all numbed up and maintain that numbness for any given length of time. But while they're doing their cut and they're using the bovie to stop bleeders and actually get down into the abdominal cavity, you're setting up and counting your major instruments and grabbing the stuff that you need and bringing them up to your Mayo stand, and grabbing your retractors and things like that. The retractors would be the things. Yeah, because once they make their incision, they get in the abdominal cavity. The next thing they're going to need is some kind of retractor to help hold that open. So if that's a big retractor like a Balfour or a Bookwalter or something like that, that's being asked after you get your major tray on your field. You're bringing up the big retractor. Not bad news. There's just questioning about this vaccination stuff. because like your flu shot and stuff, you can decline that and it's not a problem, just as long as you have the paperwork of declination. But like I said, it's now being discussed on whether or not we need the vaccination or not. So, but these are your example of your imaging systems. I think I remember talking to you about you guys. This is your main tower here, and this is the slave monitor, and it'll have a cord that connects these two together, and that way people on both sides of the table can see the image, and not one person has to like turn and kind of look back behind them, like tweak their neck and back and stuff like that, just to be able to try and see. But you got your light source, which is the box that you plug the light cable into. Right? You got the camera controlling unit. You got the camera itself. Video cables here in the back that hook up to. You got the printer, the insufflation machine, your monitor, and then one of these, the image management system. That's the actual onboard computer. So you can have it record the whole thing, and then you can burn a DVD copy for the patient. When I first saw that, I wanted to have surgery so I could have a DVD copy of the inside of me. But I'm a little weird. But yes, we have to pass off those cables off the field so they can get plugged in, which means we have to keep enough slack so that we can still use those things. We can't pass off too much of that light cord, because then we need to move the camera this way, and now we're pulling part of the cord up that's been on the unsterile surface. The light source in your fiber optic cable or your light cable, a huge patient safety issue. If the light is on, then you have control of that cable. It is in your hand. You are not setting it down on the drapes. You are making sure that that light is not touching anything, because it gets extremely hot and will burn a hole in your drape just like that. I've seen it happen where the surgeon set it down. I didn't know he had taken it out and was setting it down. I was grabbing something from the nurse. I turned back around, saw it sitting, and this was the light cord was connected to the scope, and the scope connected to the camera. It was the end of the scope that was right up against the drape, and I saw it, and I was like, oh, I picked it up, and there was a hole in the drape. It was that fast. I was like, whoa, we got a hole in this drape. I had to disconnect the scope and pass that off and get a new one to replace it. And then I put a Tegaderm over the hole to seal it back off. Scary times. But patient safety, fire safety, the light must either be on standby or being controlled by somebody. When you're wrapping them back up, you're not wrapping them real tight, because you're going to break those fiber optic cables inside, which, if those are broken, now you cannot transmit the light through the cable itself. And same reason why you're not smacking it against something, because you're going to break those cables inside. You want to try to inspect it, the outside of it, make sure that there's no holes or tears or anything in it. And then usually when you plug it in, you're going to see, little dark spots all along the cable. And that's areas where the little fibers have broken. You don't want the cable to be plugged in with the source turned on. Obviously, do not touch the bowl from the source box with your bare hands. This is one of those warning labels of that you think is like, pretty self-explanatory, and like who would grab, a light bulb with their bare hands. I mean, if you think about over the last, well, this is your guys' fourth term, right? So over about the last almost 40 weeks, think about all the new information that you've learned and been shoved into your brain. You may have lost some old information. And with some people, some of that old information is don't touch hot things with your bare hands, but they do it anyway. So that's why we gotta warn you: don't touch it with your bare hands. There should always be a replacement bulb with that box, because at any moment the bulb could go out and you could be in the middle of working, and if your light source goes out, you can't see. So that way you can immediately replace. You don't have to go running out of the nurse doesn't have to go running out of the room and go searching for new bulbs. It's already right there. That way you can immediately change it out. The telescope itself, the rigid telescope, I know we did talk about this, right? You have different angles at the end of your scope. Like your 0 degree is looking just straight ahead, right? All you can see is what's in straight ahead. But then you can angle it, right? You can go 30 degree, 45 degree, 70 degree. Typically like these 5 and 25 degrees. And I think there's a 12 degree one too, or like your hysteroscopes for looking inside the uterus. The ones you'll see most often is 0, 30, and 70 degree scopes. But that way you can look, like the 30 gives you kind of this downward angle, and then you can spin it and then get the rest of the, you're trying to look more peripheral with the 30 degree scope. The angle of the scope is going to be doctor preference. Some of them like 30 degree scopes, some of them like 0 degree scopes. Right? The time that you need to use the 70 degree scope is if you really need to see like almost straight up or straight off to the side. Typically you'll see the 70 degree scope in urology when they're looking in the bladder, and they need to see like near the bladder neck or more up on the dome, things like that. Right, yeah, here's a good picture of it, right? This is where your camera connects to. That's where your light cord connects to. And then this is where you're actually looking at, an organ or tissue or whatever over here. Sorry, I didn't catch all what that said. Gotcha. But here's more of that angled off. I see, so now 30, I can see more of what's going on kind of down here. And as I spin the actual telescope itself, then I can see in that realm of area, right? That field of view. This is the Fred, the anti-fog. You put a little bit on this green pad here and then stick this up on the drape so that as they come out with the scope and clean it off and stuff, they can get more anti-fog on it and go back in. You obviously want to check the scope itself on the outside of this for any kind of damages, right? Is the eyepiece cracked? Are there scratches or dents, on the actual viewing side, right? Are there dents along this that could, cause that image not to fully come down to the eyepiece? Things like that, right? You're inspecting your instrumentation before you use it, just to make sure it's good. And then anytime you're going to be carrying it, you're always carrying it by the eyepiece and where the light attachment is. This is the heavier end. You don't want to carry it by this because, you know, you may hit something and it may kind of bend it or dent it or something like that. Take it off lineman a little bit. Fred, this is the camera. Right? This is your focus ring right here, this gray part. This is your endocoupler. So when you push down on this, it kind of opens this circular area so that you can fit the head of the camera in there. And then when you let go, another little piece comes up and it'll lock on to that camera or onto the telescope. Typically, these are hand washed because they cannot be submerged and they cannot handle the high heat and water of the washer sterilizer. There are 3 chip cameras. I think there's even now 4K and HD cameras that they use now too. You know, better imaging. You know, the better you can see, the better, you know, you can operate on the patient, right? Then you know exactly what you're working on, that kind of stuff. White balancing. So before you start each procedure, you have to white balance your camera. What that means is usually what we do is we just put a sponge up on the field before we insert the camera into the patient. We're going to press and hold the white balance button while it looks at the white sponge. What it's doing is just calibrating so that when we get inside the patient, those things that are supposed to be red are red, those things that are supposed to be yellow are yellow, you know, green, green, blue, blue, and things aren't like these kind of weird amalgamation of colors and stuff like that. And it just helps us to see the anatomy better and to be able to pick out anatomical structures a lot easier, right? It's all about being able to see so that we can operate. But you can do all, you know, you can do output recorder. You can actually hook up like a little headset and microphone so that the doctor can even narrate to those DVD videos that the DVD that you can burn of that patient's procedure. You know, and a lot of that's, you know, good too, because then the patient can go back and rewatch that and then listen to the doctor, you know, say, hey, look, you see how this is damaged right here? This is a direct result of this. Or can you see the buildup of plaque, you know, in this particular artery or something like that? That has to do with, you know, the eating of these, and that way the patient can get a little bit more information as to, and to see exactly how their body is being affected by the choices that they make with their life and things like that. Now, sometimes, or I would probably say the majority of the time, it doesn't phase, you know, patients. They're like, whatever, you know, I'm fine now. But some people, that could be like kind of a wake up call to them. Be like, oh, wow, that's what really happens? Yeah, oh, wow. And then it kind of wakes you up. And then later, when faced with that same kind of decision, you're like, you know what, I'm going to go the opposite this way because I've seen what happens when I go the other way. I've seen it firsthand. But some of these other things, like the equipment carts, that's the thing that all these boxes are sitting on, right? So this is the equipment cart for all these different, you know, camera boxes, light cord boxes, insufflation, that kind of thing. Some specialty type scopes, right? You have the resectoscope used in urology, the laparoscope, which you guys have seen. You got to play with that one day that you were in the lab early on, getting to play with stuff and seeing kind of how surgery goes. Excuse me. Arthroscopes, those are for orthopedics, for in the joints, shoulder, knee, wrist, ankle, elbow, hip. Hysteroscopes for looking into the uterus. Thoracoscopes for looking into the thoracic cavity. The thoracoscope and the laparoscope, same scope. You're just using it in a different area. Nephroscope for looking into the the kidney, right? And then you have a cystourethroskop for looking into the ureters and into the urethra, things like that, right? Ureteroscopes. So there's some specialty scopes out there, but we're all still following the same principles of minimally invasive, right? We got to go through a cannula. We got to protect, the tissues of the body. We have to distend or insufflate that thing we're actually going into. Some of the instruments, right, can be reusable, some disposable. Some we can change how they're positioned, their pose, and they'll hold that change. Right? Anything you can kind of change the position of, but is it going to stay in that position without being broken? And a lot of them have those little, pistol type grips to them, so you can just open and close. Right? But we can use scissors. We got graspers. We got cautery. We got retractors. We have, clips that act as our hemostats. Right? We have all kinds of different ways about going and doing this minimally invasive. Right? We can do suction. We can staple. We can do all the same things that we can do open, but through the scope. All right, let's go ahead and pause there. When we come back, we'll talk about more in depth a little bit on the endoscopes, kind of those resectoscopes. And then we'll talk about like the insufflation. I know we talked about that in lab and stuff. We'll go over briefly real quick again. Make sure you understand how to perform insufflation, whether it be with the Varus needle or the Hassan trocar. Because trust me, guys, when you get out to clinical, you are going to be doing a lot of scope procedures. So understanding what's going on and how to at least get it started is going to be huge for you guys. It's going to put you, at least a leg up. So with the robotic, put that back on record, so that's actually in the thing. Yeah, you can resubmit the workbook. Sorry, getting off track here real quick. Resubmit your workbook page if you did it last term. If you submitted it last term and you got things wrong, go back and correct those things you got wrong, and then resubmit it for a nice easy 100. Should be one less thing that you got to do this week. Make sure you're working on your EALs. The robotic training. So we need those certifications from that training by before you take your lecture final on the 13th. So that should give you at least a couple weeks to get that done. Do not forget about it. I'll try to bring it up, each class meeting, remind you guys. But we need those. And what you need to do is print it out, or you can email it and print it in the LRC, or if you absolutely have to, you can email it to me and I can print it out. But we need it for your file so that when you go out to clinicals, we have evidence that you did receive that training, so you can do those robotic procedures. Make sure I got everybody here. Okay. Does anybody have any questions? I think we may have covered everything there. Comments? Concerns? Alrighty. So group B and C, you will be with Miss Kimbleton tomorrow and Thursday. You guys will be with Miss Kimbleton, I believe, all week. Then I'll be back next week for your guys' lab finals. I'm still there. I'm still here. I'm just right next door with the seniors doing boot camp trainings to get them ready for their CST exam. Um, really review that insufflation technique. And don't give Miss K a hard time. All right, you guys, we'll go ahead and call it for today.